I would like to give some clarity on the differences between the conventional and the corticobasal implantology. As Robert Frost said, two roads diverged into the woods, and I took the road less traveled by, and that's made all the difference. Why do I say less traveled by? Is I practice corticobasal implantology, and that's a very exacting science. I need to have my implant stocks, my lab, and all the staff to be ready when I place these implants, because I have to finish the case in 72 hours. Why I have to finish in 72 hours? I've already told you in the previous videos. Today I'm talking only about the basic differences. When we go into the concept, implantology was practiced by the founding fathers in Europe, basically in Italy. There was a doctor, Formigini, in the 1940s. He had used tantalum alloy to place the implants, and he had good success. He was in Modena. They had called him and they had bestowed their respects on him because he had cases which were working for 5 years and 10 years, and the results were fabulous. Following this, in the 1960s, there was Dr. Stefano Tremonti and the American doctor Leonard Linko and Garbaccio and Muratori, and there were just too many doctors who were practicing the immediate loading science, which is the corticobasal implantology basically. It was based on the concepts of orthopedics. So as soon as you place the implant, you can load it and bring it into function. And then came the Swedish concept by Dr. Per-Ingvar Brånemark, and he told the exact opposite. He said, you place the implant and you wait, let it heal, and then you go and load it. The miraculous thing was, it was very well accepted by the doctors because it gave the doctors a certain amount of time for them to place the implant and then plan the restoration and then go about doing the work. Both have their place in dentistry, and both are concepts which are fabulously successful. Now it is up to you as the patient who are going to actually get this process done for yourself to decide, do you want to go with immediate loading or do you want to go with deferred loading? You want to wait and then get it done. It's up to you. I will just give you the key points for you to decide. Now let's look at the concept. The concept is, one is the implant which is engaging the basal bone, and the other is the implant which is engaging the crestal bone, the crest of the alveolar ridge. After you remove the tooth, there is the superficial portion of the gums. You elevate the gum, and whatever bone is available there, to that length you select a implant and place the implant, wait for it to heal, and then you go about making the teeth. Or whatever condition the ridge is, you are having mobile teeth, the teeth are infected, the teeth are broken down, you just simply extract that. We trim the bone or we remodel the bone and place the implant inside, engage the second cortex so that you're having a very firm engagement, and immediately make the teeth and load the restoration. This is the immediate loading concept. This is the difference. What are the indications? When you look at the indications, when you have adequate bone, when you have a good bone height and width of the bone, then it is very easy to practice the deferred loading or the crestal implantology, or what we call as the so-called conventional implantology, where there is very less bone, or the teeth were infected and you had to remove it due to a gum problem, or the patient is you are already wearing a denture for many years, which has resorbed the bone so much that there is literally no bone there. There is no way to make a new denture for you. Dentures are already floating in the mouth. In such a situation, the ideal solution will be to go with immediate loading corticobasal implants. So when there is a poor bone, when there is a infected teeth, when there is no other solution, then as a last resort, definitely corticobasal implant is the only way to go. But you can also select this when you have a good bone and you get a good engagement and place these corticobasal implants and make your restoration because of the time frame. The time duration is 3 days as compared to 3 to 4 months when you do the conventional implantology. You have to place it inside. There is a certain period of healing which is required, and then you go and open up that region where you place the implant, which is to place the next portion, which is the abutment portion, has to be fixed inside. So we put the gingival formers, place the abutment inside, and then take an impression and then proceed. So when there is good bone, the choice is yours. You can either get it done in 3 months or in 3 days. Next is, what is the mechanism of engagement? What is the concept on which these implants are engaged? One is when we go with the conventional implant, the crestal implants, the implants which have to be placed and given a time period to heal. Those are working on a concept as explained by Dr. Brennemark called as the osseointegration. You have to create an implant bed, put the implant inside, wait for the new bone to form and integrate between the titanium implant and the bone. It forms a direct contact. Once the direct contact happens, we know that the implant has successfully integrated inside the bone, and we go about with the next further steps. Suppose the integration does not happen, then what do? You have to remove that implant, allow it to heal, or place another bone graft in that region, and then go once again by placing another implant. And once again you go through the same process of so many months of waiting and all that. When you compare it to the other system, which is the corticobasal system, it works on a concept called as the osseo-fixation. It enters into the ridge and reaches the second cortex, which is there will be a target bone which is on the other side, which will be the nasal floor or the floor of the sinus or the pterygoid plates or the zygomatic arch. There are many areas which we can use these bones. The basal bone which we are targeting as the second cortex is always available because these are skeletal bones. 85% of the bone is cortical bone in the whole body, so there is ample amount of bone available. So you go and engage these bone and then bring the implant inside the mouth and make the teeth on it. This concept is called as the osseo-fixation. Osseo-fixation happens immediately. So as soon as I place the implant, the amount of torque that I am going to get when I engage the implant, let us say it is between 60 to 90 Newton torque, then I know it's really firmly engaged and I can go and load this implant immediately, and I know this implant is already successful. I don't need to wait 3 months to find out that this is going to work or not. The variable in this is the prosthetic portion, the teeth, how the forces are going to dissipate from the teeth when the patient is eating into the surrounding bone. So once again, the onus is upon me on how to make those teeth and allow the forces to dissipate correctly. Okay. Next is, how do you select the patient? Patient is a, let's say, compromised health. The patient is a smoker, having diabetes, and if there is he is undergone any transplant procedures or basically any systemic problem. In that case, the alveolar implants, the crestal implants, have certain limitations because they are rough surface implants and they get infected very easily by it goes through a process called peri-implantitis, which means the implant surface of the implant, the around the implant, there will be inflammation happens, leading eventually to the failure of the implant. This is not favorable for you as the patient. The corticobasal implant are very thin implants and with a polished surface. So whatever the systemic condition, in most of the conditions, say like diabetic patients, smokers, it simply does not make a difference because we are engaging the cortical bone, and secondly, it is sitting inside a bone which is there is having any hardly any metabolic activity. It just simply goes and locks inside that bone, and the stem of the implant over a period of time will also get osseointegrated like the other implants. Osseointegration happens, but it takes a little bit of time for it to happen, 3 to 6 months time. Once it eventually integrates, it is rock solid. So now, what are the benefits? The patient need not undergo the sinus lift operations where there is a very less bone, or you don't need any bone grafts. You can get the work done immediately as soon as you decide. Now, it's up to you to decide, do you want to go in a long route, or you want to go in a route where the control is totally with us. We don't need to wait for the body to heal at all. Straight away we place the implants, lock it into the desired bone at a very good torque, and then make the teeth which will look aesthetic, and you can start bringing it into gentle function, and 6 weeks later it's integrated perfectly. These are the major differences between the conventional and the corticobasal system, which I wanted to tell you about. I hope you are clear about this. If you have any further doubts, don't hesitate to ask me. Thank you.